I want to take a moment to say thank you for our generous sponsors for their support for our educational programming and community services, CSL Behring. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice. Immune Deficiency Foundation education events offer a wide array of education presentations, including presentations developed by healthcare and life management professionals. Invited to serve as presenters, the views and opinions expressed by guest speakers do not necessarily reflect the views and opinions of IDF. And now I get the honor to introduce you to our presenter, Dr. Cohen. Dr. Cohen is the head of the Dermatology Consultation Service at the National Institute of Health. Dr. Cohen specializes in the evaluation of rare and challenging dermatologic conditions and has participated in the initial description of several syndromes first described at the NIH. If you would like to read more of Dr. Cohen's bio, you can find it on the conference app. And help me introduce our presenter with applause to Dr. Cohen.
All right, well, thank you very much, and it's an honor to speak to this group, and I am so impressed that everybody's here, packed this room just to talk about skin disease. So Dr. Heller, who's my colleague, is a tough act to follow, but and my accent is not nearly as exotic as his. But we're going to talk about a much more interesting organ than the liver. We're going to talk about the skin, which is also the largest organ in your body. So I do not have any financial conflicts. I am an NIHer, like Dr. Heller. Do not have any relationships with the pharmaceutical industry. And what I'm going to talk today in sort of overarching terms are my opinions and should not be considered to be those of the U.S. government or the NIH. So both Dr. Heller and I work at the Clinical Research Center, which I think, just in talking with some of you, many of you who are patients might have experience with the clinical center. Our hospital is not called the hospital, it's called Building 10, and this is where we have patients come from around the world, many of whom do have primary immunodeficiency, and that's where I've been fortunate enough to have an opportunity as the consultant dermatologist to see many of you and learn about many of these skin conditions. And so what we do in medical conferences, because we want to make sure people learn things, is we often will give the participants a pre-test and then we ask them again at the end. And since this is a patient conference, I'm not going to ask any of you to diagnose these things, but we're just going to do this for fun. And so the question is, which of these two patients have skin changes associated with a primary immunodeficiency? On the left, you can see a man who's got this reticulate pattern of redness with pigmentation sort of limited to the central chest. And then on the right, someone who has a slightly different pattern, but still sort of interconnected red markings on the lower extremities. And so you have to stay to the end of my talk, and I'll give you the answer. All right. So this is what we're going to do today over the next 25 minutes. I'm actually going to start with what to look for in terms of dermatologists, and then we'll talk about some key dermatology concepts that I think are particularly salient for you all. And then because the skin is an external organ that you all can see and you're all intelligent people, I want to try to empower you in terms of what to do to take care of your skin, to help diagnose your skin condition, and to be as proactive as possible. All right, so why do you need to see a dermatologist at all? You have many other doctors that you're probably seeing on a regular basis. So really, we are the experts for diagnosing your problem, and by default, we usually think about skin infections in the primary immunodeficiency setting, but there's many other skin things that can occur. Skin cancer is a higher risk problem. 1 in 3 people of European extraction will have a basal cell carcinoma, and these are people who have a normal immune response. And so this is much higher, obviously, in people whose immune system is suppressed, and particularly with squamous cell carcinoma, which is a more aggressive form of skin cancer. So this is a big problem in the general population and even more so in the PI setting. We can be helpful for diagnosing an allergic reaction you're having. You know, many people are on, 10, 15, 20 different medications. And so helping to identify the type of specific drug hypersensitivity and how to manage it, and also the long-term side effects. So oral steroids, for instance, will cause stretch marks or stria, long-term acne and rosacea, all the other side effects that you can get because of these other medicines you need to take. At the table I was at, we were actually talking already about some autoimmune skin issues and things like lupus and vitiligo, alopecia areata, which is the autoimmune form of hair loss. These things are all more common in the PI setting, as are inflammatory skin diseases. And so this includes eczema, but other types of dermatitis as well. And then you may be left with damage to your skin. And this could be pigmentation, what we call post-inflammatory pigmentation for where you've had skin damage. There could be scarring or keloid formation or hair loss. And dermatologists can all help manage some of these concerns. And then lastly, I think there's an important role for education. And so all of the things that you can do to be as proactive as possible to care for your skin and limit the risk of getting infections, limit skin cancer, for instance, are things that are useful. Okay, so you've decided you are going to actually see a dermatologist. What makes a good dermatologist? Not necessarily Dr. Pimple Popper. This is what we usually all think about when we think about dermatology these days. Please do not call your dermatologist Dr. Pimple Popper. That will not be a good start to your visit. So who is the right person to actually look for? So dermatologists, you may have experienced, tend to schedule patients very tightly and very quickly. And so you want to find someone who's going to take the time to perform a full skin exam for you. You may have a specific lesion of concern that you've identified, but there may be something else that you're not aware of that has changed or is of concern. And so usually at least once a year your dermatologist should offer that or be willing, but there's no reason you can't ask at the beginning of the appointment, can we just do a full skin exam? You also want to find the dermatologist who's willing to slow down and take the time to listen to your unique concerns. So obviously skin infection and making an accurate diagnosis of that infection is very important. And it may not just be a skin swab. What a swab does with a Q-tip is it just gets the superficial microbiome. Even if you have an erosion or an open sore in the skin, that's just testing what's on the surface. And so for some infections that are more difficult to diagnose, the culture has to be taken with an actual biopsy, and dermatologists are going to be the ones that are going to do that typically rather than the infectious disease doctors. We talked a little bit about some of the damage that can occur in your skin after you've had infection or after you've had other problems, and so scarring and discoloration may be more suited to a dermatologist that does work with cosmetics or a cosmetic specialist. And you really want to find someone who's willing to talk to the other experts in your disease. And so someone who's willing to network with your providers, willing to call them after hours if they're not going to call them in real time, and be aggressive with managing. And to be aggressive, they need to talk to your doctors and make sure what they're allowed to do, what's safe to give you, particularly when you're talking about systemic treatments. And lastly, you want a dermatologist who's willing to be educated. You, in many cases, are going to know more about your condition than your dermatologist. Most of the time, there's now patient portals where they want you to upload information ahead of time, so you can provide additional information, but always bring a copy of that information with you to the appointment. And then obviously, if you've had previous skin cultures or skin biopsies, if you have a paper copy of those biopsy reports, it can be very difficult to remember what you had 10 or 20 years ago. But if you can bring those reports, that may avoid going through another skin biopsy. And then lastly, dermatologists do different things. And so obviously, we think about someone who, if you have a skin, a hair, or a nail problem, those are the dermatologists. But there are people that specialize just in skin cancer surgery, and that's called Mohs surgery. And so this is a fellowship after regular dermatology where they focus primarily on removing skin cancers from the face to try to minimize the size of the scar. Some dermatologists are also pathologists, but they do clinical care as well, and that's totally fine. And then there are dermatologists that do almost entirely sort of specific procedural work, like a laser specialist. And that might be okay if that's the type of procedure thing that you're looking for. And the same holds true with cosmetic dermatology. There's lots of options for things that can be done for procedures, but fundamentally, if you're looking for good care as a long-term sort of dermatologist, if you're a pediatric age, I recommend finding a pediatric dermatologist. And this could be at an academic center, or it could be a pediatric dermatologist in the community. And if you're an adult, someone who specializes in medical dermatology. And then these individuals can certainly refer you on to a laser specialist if you're going to require a laser procedure, get you to a Mohs surgeon if they diagnose you with skin cancer, but you want to sort of look for those two types of dermatologists in particular. So how do I find that person? Primarily start with your primary doctor, your immunologist, your infectious disease doctor. They'll know who they recommend to help care for you. Patient support groups like this are outstanding resources. But what everyone can do is just look at the website for the dermatologist you're thinking about. And you can learn a lot just from looking at that website if they're more cosmetically focused, if they talk about the diseases that they manage and treat, and it's more medical dermatology or internal medicine type diseases. That's probably going to be a better fit for you than a practice that seems to be primarily oriented towards cosmetic procedures. And in general, the academic medical centers are good resources. There's pros and cons in terms of having residents and rotating people that you may not always have the same provider. But you can still look at the website even for the academic specialist, and we just did this earlier trying to find a specialist in oral medicine who also is a dermatologist. And so you can learn a lot about the specific interests of these medical dermatologists. All right, so we're going to move on now to some concepts to consider in the dermatology setting. So Theo showed a paper that was called The Tip of the Iceberg. I think dermatology is even a more apt metaphor, because if you think about the world of primary immunodeficiencies, what dermatologists do is deal with that subset of patients who have skin problems that are visible, and this can be important for diagnosis and management. And so, we're dealing with the PIs that have skin findings on the surface. So the first tenet is that common things are common even in people who have immunodeficiency. And one example is molluscum. This is a type of benign viral infection that almost everyone will get when they're a child, but in the PI setting, they just tend to be more difficult to manage. They might last a little bit longer. So these are skin-colored papules that tend to have a little dell in the middle, and that's what you're seeing in the schematic picture here. They can occur anywhere in the body, but they like to be in the skin folds, and they're about the size of a pencil eraser, a little bit smaller. And they're no medical concern or medical consequence, but some people will get eczema around these areas, and so they might complain of itching or irritation. And just to show an example of how this can be a bigger problem in the PI setting, this is a patient who has DOCK8 combined immunodeficiency, who has nearly confluent involvement with this type of virus. Warts are also extraordinarily common. The medical term for this is human papillomavirus. The important thing to know about warts is that there are over 100 different subtypes. And so when people say warts, they're referring globally to this type of virus, but it means very different things depending where on the body you're dealing with the virus. Okay? And so when you have warts on your hands or feet, it's a different subtype than typically you would get in the genital skin. And it's the type that occur in the genital skin that are a much bigger concern as a long-term health risk. And I'll show you an example of that. So this is a listing of some of the sort of mucosal surfaces and the cancers associated. So cancers of the oropharynx, the genital skin, and cervical cancer, which, as you know, is a major issue in females. And then in the bottom are the percent of those in men and women that are HPV associated. And you can see cervical cancer is nearly universally caused by HPV. But a large percent, both in men and women, of anal cancer and cancers in the oropharynx, the mouth area, are also caused by HPV. And so this is a very particular concern from a population standpoint, but also particularly for patients who have primary immunodeficiency, because the risk goes up even more when your immune system is not fully functional to be able to fight off this long-term viral infection. And so in the setting of primary immunodeficiencies, secondary immunodeficiencies when patients need to be on immunosuppression, and then in the HIV/AIDS setting, the risk is considered a higher at-risk population. But fortunately, there isn't a vaccine for the high-risk types, and these are the types that are most commonly associated with genital skin infection. And so this is recommended for all individuals, as children, but patients with primary immunodeficiency as well. And you can see this has had a dramatic impact in the prevalence of HPV infections in young women. But we also see uncommon infections in the primary immunodeficiency setting, and that's why you need a dermatologist who's going to sort of consider things other than just normal fungal infections and bacterial infections, impetigo, things like that. And one example is a type of particularly unique infection called Flexospira. And we see this infection almost only in patients who have a particular primary immunodeficiency, and it's difficult to culture. And so unless you're looking specifically for it and you're doing a special stain called a Warthin-Starry stain, it may be missed. And these are two examples of patients that we saw at the NIH. They were treated as non-infectious ulcers on the legs for many years and had just very extensive infection because they were actually being treated with steroids, the opposite of how you'd want to treat this infection, before the diagnosis was made and we could get them appropriate antibiotics. Another example of a less common type of infection that you have to have a suspicion for is mycobacterial disease. And mycobacteria are ubiquitous in the environment, but most people who have a normal immune response typically aren't going to manifest manifestations of mycobacteria in the skin. And you can see sometimes it can look pretty subtle, and unless you're thinking about the possibility of this and you're doing a special culture called a mycobacterial culture and special stains, you may not be able to detect this as quickly. So key points to take home: common infections are certainly very common, warts, molluscum, but they're just more difficult to treat in the primary immunodeficiency setting. And in general, we don't have good curative treatments for any viral infections. Destructive things can be used, and so for both warts and molluscum, we do cryotherapy, which is liquid nitrogen. There's other destructive therapies you can do, topical acids. And then there's a treatment called imiquimod, which is a topical cream that actually works to rev up your immune response locally to try to treat these viral infections, but it's not always particularly useful in the PI setting. Very important to have a complete skin examination, and this should include the genital skin. And for females, if your dermatologist is not doing that, making sure you see a OB-GYN to do that, to make sure there's no undiagnosed HPV infection. And then your dermatologist needs to have a low threshold to perform skin biopsies for tissue culture if there's a suspicion for a possible infection. And then lastly, HPV vaccination, as we talked about, is very important. But not all skin issues are infections, and it's a bit of a catch-22. You may have a suppressed immune response, but yet you still can get this tendency for eczema, which is sort of a aberrant excessive immune response in the skin. And so we have the challenge of trying to calm down this excessive inflammation in someone whose immune response is already suboptimal. And so doing this really does require coordination with your immunologist or your infectious disease doctor. Patients who have bad dermatitis are also prone to get secondary infections. And so the term impetigo is typically that sort of crusty yellow material that you'll get on top of the skin, and this is usually staph or strep. And this occurs when there's been a break in the skin barrier. And so you may have chronic eczema, but superimposed on top of that may be other bacterial issues. And then on the right is an example of someone who actually has HSV, herpes simplex, and this is the virus that's typically around the mouth or in the genital skin, but when you have bad eczema, the skin is open, and it's actually easier to get this virus in other parts of the body that you normally would not normally get HSV infection. So here's some guidelines in terms of how I think about managing dermatitis in this particular setting. You want to do everything you can as a patient to try to keep your skin as healthy as possible. So gentle soaps, lots of emollients, ointments, which are Vaseline-based, are going to be much better moisturizers than things that come out of a pump, which are lotions. And so there may be a limit to how greasy you want to feel, particularly during the day, but at night, if you don't mind putting a greasier ointment on, that's going to help moisturize your skin better. For particularly a lot of our PI patients that have issues with secondary infection and impetigo, we recommend they actually go in a swimming pool as often as possible. If they don't have access to a swimming pool, doing very dilute bleach baths with just a very small amount of chlorine helps as a topical decontaminant to help decrease the risk of staph superinfection. And then we do see more allergic disease in general in our PI patients, and so you want to avoid any triggers that you know may cause hypersensitivity. So foods, fragrance is a very common cause of dermatitis, or any other environmental triggers that you know of. How do we manage eczema? So topical corticosteroids are the mainstay of treatment, but they're not all created alike. And so it's very important that you have a dermatologist that's helping you understand which topical steroids should be used on which part of the body. Clobetasol, which is the one in the middle here, is considered an ultra-potent steroid, and so it's 100 times stronger than your typical over-the-counter hydrocortisone. You can't just look at the strength. So hydrocortisone over-the-counter might be 1%. Clobetasol is actually 0.05%, but again, it's 100 times stronger. It should never be used on the face. It should never be used in the skin creases because it will cause stria very quickly, the stretch marks. So if you're on topical steroids, which work very well, it needs to be managed and you need to follow up. And if you then improve and you can go off those topical steroids, that's a very safe way to do that. But in some patients, that's not possible, and you may have to think about other alternatives. Wet wraps is a technique where the steroids or just an emollient may be wrapped with gauze that's wet, and that helps increase the penetration of the steroid into the body. And that works, for, again, as a skin-directed treatment, particularly for patients who we can't put on systemic immunosuppression. And then there are topical agents that are not steroids that, again, we can use particularly on sensitive areas of the body, like in the face, tacrolimus topically, pimicrolimus, which is called Elidil. These are agents that don't cause the risk of stretch marks. They won't cause other side effects we see with topical steroids. And then very recently, topical ruxolitinib, which is a JAK inhibitor, came on the market, and it's used both for eczema as well as vitiligo. And this, again, is not a topical steroid, and so this could be an option as well. Antimicrobial topical agents have a limited role. If you're diagnosed with impetigo or sort of a localized infection, that might be reasonable, but many patients do end up needing to be on a short course of systemic antibiotics. And patients with bad eczema, if they just go on oral antibiotics, often their skin will improve as well, and that just tells you the importance of the skin microbiome and triggering eczema in a lot of our patients. And lastly, there's a systemic treatment called dupilumab. And again, this needs to be done in conjunction with your immunologist or your infectious disease specialist. But the nice thing about this particular agent, which has been around now for over a decade for kids who have eczema, is that it targets a very specific sort of cytokine in your immune response. And so it's not a broad immunosuppressant like oral steroids. And so we've had success with a lot of our PI patients who have refractory eczema and are able to do very well with dupilumab, or Dupixent's the trade name for that one. And of course, not all things are eczema or infections, and I just want to give you a couple other examples of some other skin conditions that you might encounter. We see much more autoimmunity showing up in the skin, and so one example of that is cutaneous lupus. That's classically that butterfly pattern that you see in the cheeks in women, but cutaneous lupus can appear on many other areas of the body, and it's much more difficult to diagnose in that setting. Chronic granulomatous disease is one of the PIs that we see a lot of autoimmune lupus-like rashes, and you can see in the upper right here, it can look like ringworm with a well-defined circle, or it can look less specific with just these red papules on the upper back. Patients who have autoimmunity in the skin will often be photosensitive. And what photosensitivity means is that you'll get a sunburn very easily, and this can be as short as just a few minutes outside in the sun. And so if that occurs, and if that's a new change, that's something you want to make your doctor aware of right away. It may be due to a medication. I'll show you some examples of that in a second, but it may be that you have a new autoimmune issue that's developed in the setting of your immunodeficiency. And on the right is an example of a type of lupus called discoid lupus, and it actually causes scarring, particularly in the head and neck area. Alopecia areata is, as I mentioned, the tendency to lose hair in circular patches, and this is considered an autoimmune phenomenon, and we do see this more in a number of PIs, including autoimmune polyendocrinopathy. These patients get vitiligo as well. Vitiligo is the autoimmune form of pigment loss. One of the things that your dermatologist may do is use a special light, which is a Woods lamp, which is that ultraviolet light that can accentuate that skin pigmentation. For people who have very fair skin, it can be sometimes difficult to see where vitiligo starts and stops. And one of the agents that I talked about a little earlier, ruxolitinib, which is a JAK inhibitor, which is a new class of medicine, has recently been shown to be very beneficial for some of the autoimmune features that can be seen with one particular primary immunodeficiency, the autoimmune polyendocrinopathy. And last, I'm going to close with what can we do proactively to help optimize your skin health. So at the start, we talked a little bit about skin cancer. So basal cell carcinoma, 1 in 3 individuals of European extraction are going to develop a basal cell skin cancer. This looks like a pearly papule. Typically, you may think it's a little pimple or some skin blemish, and it just doesn't heal, doesn't go away. They grow extraordinarily slowly, so they're not going to basically ulcerate and turn into a tumor for many, many years. But if you can diagnose it at this very early stage, then it's a much smaller surgery. Basal cell carcinomas have no risk of metastases. They're not dangerous. You just want to remove them when they're as small as possible to minimize the surgery. Squamous cell carcinoma can look a lot of different ways, but often they're just going to be a non-healing red area with a little bit of crust or scale, this yellow stuff on top. These can develop eventually into sort of a more tumor-looking, obvious looking skin cancer. But again, you want to catch this as early as possible. So if you have an area that you think is eczema but isn't getting better with topical steroids, or it's clearly not healing, it's possible that it's a squamous cell carcinoma, and these are certainly more common in the PI setting. In terms of skin reactions, we talked about when you're on lots of different medications, it's very easy to sort of get confused regarding what's causing a particular skin reaction. So antibiotics in particular are very common causes of hives or urticaria, and these are sort of the edematous sort of pink welts that move around. They're going to move every day, and by definition, they move around. So if it stays in the same spot, it's probably not urticaria. On the right, this is what we would call your more typical drug rash. So this is a delayed hypersensitivity reaction, whereas hives usually occurs within the first 24 hours of being exposed to a medicine. A drug rash might not occur for a week or so until after you've started that medicine, particularly if it's the first time you've ever taken it. If you do get a drug rash like that, and for whatever reason it wasn't diagnosed and you take it again, the rash then may come back within a day or two of that second exposure. But if you're thinking about the possibility of new medicines and you see new skin eruptions, it can clue you in to call your doctor right away and make sure you get the accurate diagnosis. And then there's a number of other antibiotics that you may be exposed to that don't cause a typical drug rash, and so it may not be diagnosed right away. And these medications all cause photosensitivity. And this is what I showed you in my example of lupus-type rashes. You'll get a sunburn much more quickly in the location of where you're exposed to the sun. And so this can be redness with peeling, just like a normal sunburn, or you can get actual blisters, and we call that pseudoporphyria. When people have erosion of the lower lip but not the upper lip, that's a hallmark clue because your lower lip gets much more sun than your upper lip. And voriconazole, which is an antifungal medicine that has been broadly used for many years for PI patients, is the setting where we really first diagnosed this as a major problem with this particular antifungal drug. It's a great medication because it's an oral pill. You don't have to be hooked up to an IV. But many of the patients that were on it long term, many of our CGD patients and other PI patients, would come back and they'd have horrendous sunburns because they're out and about and they're getting exposed to sun, even minimal amounts of sun exposure. It's a little bit hard to see here with the lighting, but intense erythema on the hands. And then voriconazole is also a unique medication because not only does it make you very sensitive to the sun, but it actually ages you more quickly. That's called photoaging. And so this is a young lady that we reported who had freckling on the hands and on the face at age 15 after exposure to voriconazole. Okay. And the other reason I want to point out this medication in particular is because if you are a PI patient who has been on voriconazole or currently on it and you develop a skin cancer, particularly squamous cell cancer, we know that that's a definite association as well. And the product labeling has actually been changed to reflect that. And I think most doctors are aware of this potential association, but you want to make sure that if that's diagnosed that you ask to be switched to an alternative agent. And this is a study we did looking at lung transplant recipients. And because they need to be on prolonged systemic immunosuppression to prevent loss of the transplanted lung, they often will be put on voriconazole long term just to prevent that lung from developing fungal infection. And so it was an opportunity to look at long-term treatment with voriconazole in these patients. And in this cohort, we had over 1,000 squamous cells developed, and what we were able to show is just 3 months of treatment with voriconazole increases your risk of developing a squamous cell cancer, and then that risk continues to go up every 3 months by 5%. So again, the main thing is if you've been on that medicine or you get placed on it, if you develop photosensitivity or you develop a skin cancer, encourage your infectious disease doctor to try an alternative agent. And last thing I'll do is just give you some general tips for skin cancer prevention. So for sunscreens, I like mineral-based sunblock, so this is titanium or zinc oxide. These are considered to be safer based on the FDA monograph on sun protection. You do still need to reapply them. These are the ones that tend to be a little bit more opaque looking, but if you're going to be out for prolonged periods of time, you're going to be in the water, you do still need to apply even a good, high SPF sunblock again. If you're not going to be outside, but you just want to protect your space in general, you can use a moisturizing lotion that has sunblock, and that's fine. Wearing a hat is always superior because the hat's not going to wash off. Definitely if you have a broad-brimmed hat. Most guys do baseball caps, so just remember to put sunblock on your cheek and on your ears. These are areas that get a lot of sun damage, and skin cancer removal on the ear is not a fun place to have surgery performed. Whenever possible, you want to wear sun protective clothing, and we talked a little bit about long sleeves. I think it's much more accepted now. A lot of people just do that because it's much easier than reapplying sunblock. If you have a choice, limiting your sun exposure to the non-peak hours of the day, and obviously if you're doing water sports and other winter sports, be aware that you can definitely get sunburn from those settings as well. And then when you're not doing your activity, just find shade, and that'll help quite a bit. A single use of tanning bed has been associated with risk of melanoma, and so nobody in the PI setting or otherwise should ever be using a tanning bed. And you can get your vitamin D from the diet. Vitamin D is obviously very important, but it's not a reason for you to get ultraviolet damage. And lastly, at least once a month when you get out of the shower, just take a look front and back, at your skin. You're not supposed to be able to diagnose all of the things that we talked about. If you see something different that doesn't look right or you think has changed, you don't have to wait a full year to see your dermatologist again. Get in sooner, and then you can potentially get diagnosed quicker. All right, so we're going to close with a test again. So which of these skin changes were associated with primary immunodeficiency? So first we'll do the one on the right. This is a pattern called livido racemosa. So it looks sort of like the pattern you see when your skin gets cold, that mottled look, okay? But it's a little bit more prominent and not quite as nice and lacy. And this was a syndrome that was first described at the NIH about 10 years ago. And it's an important finding because young people who actually have this have a high risk of stroke, and there's an excellent treatment now to prevent them developing strokes. Once we learn more about the full spectrum of this condition called deficiency of ADA2, we learn that there's actually many, many different other findings as well, and that includes immunodeficiency, and it's now included in most primary immunodeficiency testing panels. Okay, well, what about the one on the left here? Well, this patient also has a primary immunodeficiency. He has got common variable immunodeficiency, but this patient also has chronic chest pain and nausea, and he's actually been applying a heating pad for many, many months to his chest. And so this is a skin change called erythema ab igne. And so whenever we see a pattern of sort of localized skin changes like that with that reticulate pattern, it's almost always something that the patient has been doing to treat their pain or discomfort. And the medical term is erythema ab igne, and you can get it almost anywhere on the body, wherever you're applying a heating pad. And they talk about it from cell phone use, which I've never seen. And then they talk about it from laptop use. For whatever reason, they say normally it's more common on the left thigh, but they actually call this academic branding. Once everybody got laptops with hot batteries, we saw a rash of increase in this pattern of reticulate pigmentation on the thighs. And so he has an immunodeficiency, but not everything that can occur in the skin is necessarily from a primary immunodeficiency. And so with that, I will close and happy to take questions if we have any time.